Sorry, crap. I'm Dr. Chuck with CMAC. So today we're going to continue with our anatomy review of the heart valves. And the previous review video, I mentioned about the location and the function of these valves. And you can see that video right here if you have not seen it. Today, I'm going to be talking about the clinical relevance of these valves and the question that you guys might face in your board exam, such as the USMLE. And I'm sure most of you are tired of hearing me saying this, but to master these medical science topic, it's not about how smart you are, it's not about how clever you are, it's all about repetition. It's all about, practicing, doing your questions, your Qbanks, and having discipline in your study, Repetition will bring these medical knowledge that you've learned into your long-term memory. So we're going to talk a little bit more about the anatomy of these valves before we get into the clinical relevance, right? So as you know from the previous video, the function of these valves is to make sure the blood move through the heart in a forward direction, right? Prevent any regurgitation. And so let's have a look at the AV valves first. The AV valves are the atrial ventricular valves, and these valves are situated between your atrium and your ventricles. So makes sense, right? AV valve, atrial ventricular valve, between the atrium and the ventricles, right? So on the right side, you have the tricuspid valve. On the left side, you have the mitral valve, or another name of it is the bicuspid valve. And what happens is these valves open up during ventricular diastole. So when the ventricle fills with the blood, these valves open up. And during ventricular systole, when the heart pumps, when the ventricle contracts, these valves close tightly to prevent the blood regurgitating back into your atriums. So it makes sure that, on the right side, the ventricle pumps and the blood will go to your lungs. And on the left side, when the ventricle pumps, the blood will go into your aorta and go into your systemic circulation. So these atrioventricular valves, they have leaflets on them, right? And the leaflets of the valve are connected to a structure in your ventricle. And that structure is called the papillary muscle. So what connects the leaflets of the atrioventricular valve to the papillary muscle in the ventricle? What connects them is a structure called chordae tendineae. What is that? Chordae tendineae is like a fibrous cord of connective tissue. They're also called the heartstrings. So a structure that connects between the leaflet of your ventricle to your papillary muscle of the ventricle. And what's the significance of this? So what do you think? So before the ventricle contracts, before ventricular systole, the papillary muscle contracts. And what happens when the papillary muscle contracts? It pulls on these heartstrings, right? It pulls on these fibrous cord. And when the chordae tendineae are pulled, it pulled on the cuffs, pulls on the leaflets to close the atrioventricular valve tightly. So that prevents any blood to regurgitate back into your atrium during ventricular systole. Okay, the atrioventricular valve on the right side is called the tricuspid valve, right? And tri means three. And so that's because there are three leaflets on the tricuspid valve. So tricuspid, three leaflets, right? And on the left atrioventricular valve, that's called the bicuspid valve. So can you guess how many leaflets there are over here? Bi means two, right? So the bicuspid valve have two leaflets. And another name of the bicuspid valve is called the mitral valve. So we can call the bicuspid valve the mitral valve also. Another important structure in the bicuspid valve is called the mitral annulus. And that basically is a fibrous ring that's attached to the leaflets of the mitral valve. And the clinical relevance is that the mitral annulus maintain the shape of the mitral valve, and it also during contraction, during when the heart pump, it reduces the surface tension as well and makes sure that the valve closes more tightly to prevent the blood from the left ventricle to regurgitate back into the left atrium. And this is very important because the pressure in the left ventricle is very high, right? It's very high pressure area because the left ventricle has to pump very hard for that blood to go into your aorta and into your systemic circulation. So the left ventricle is what maintains the blood pressure throughout our body. So therefore, it has to pump pretty hard. So the seal of the left mitral valve has to be pretty tight to prevent the blood from regurgitating back into the left atrium. So the mitral annulus and the mitral valve are very important in making a tight seal during ventricular systole. And of course, we have the semilunar valves, right? Semilunar, semi means half, lunar is moon, so half moon. So these valves are called semilunar or half moon because they kind of look like a moon, like half moon. So we call them semilunar valves. And they're pretty simple valves. The valves are similar to the valves that we have in our veins. So no fancy structure like chordate tendonier, like the AV valve or anything like that. These valves are very simple. And on the right side, semilunar valve, you have the pulmonary valve, and on the left semilunar valve, you have the aortic valve. And basically, the function of these valves to keep to prevent the blood from regurgitating back into the heart, especially during ventricular diastole. So on the right side, the pulmonary valve wants to make sure that the deoxygenated blood goes into your lung and doesn't regurgitate back into your right ventricle during ventricular diastole. Same as on the left side, the aortic valve wants to make sure that your oxygenated blood goes into your systemic circulation, goes to the rest of your body, and doesn't regurgitate back into your left ventricle during ventricular diastole. So these are the functions of your valve, and basically the function of the valves is to keep the blood moving through the heart in one direction, in the forward direction, and to prevent any blood from regurgitating back. So now let's finally talk about some clinical relevance. What kind of concept do they like to test you on in the board exam? So they like to concentrate around the concept of valve stenosis and valve insufficiency or valve regurgitation. So stenosis, that's narrowing of the valve, right? And valve insufficiency or regurgitation is when the valve doesn't close properly, and when the heart pumps, the blood would regurgitate back into the previous chamber. So they like to concentrate around these concepts, and usually they would test heavily on the valve on the left side of the heart. Why is that? As I said, the pressure on the left side of the heart is a lot higher than the pressure on the right side of the heart. So with higher pressure, there's going to be a lot more valvular defects, and you're going to see a lot of test question on the mitral valve defects because the pressure between the mitral valve and the left ventricle is just so high. There's going to be a lot of pathological disorder there that they can test on. Okay, let's talk about the right side of the heart first. What kind of question can you expect to see on your board exam on the tricuspid valve? Well, usually they don't ask that many questions on tricuspid valve, but I can guarantee you they probably will ask you about endocarditis that has to do with the tricuspid valve. So they might ask you about tricuspid regurgitation secondary to endocarditis. And usually I have to mention that the tricuspid valve, usually you don't see too many defects. If there's a defect, it's a congenital defect or anything secondary to the patient being an IV drug user. So an IV drug user could have endocarditis, which may cause tricuspid regurgitation. You may see that. And for those of you who forget what endocarditis is the inflammation of your endocardium. And of course, the endocardium is the muscle layer inside the chamber of your heart, right? That's the endocardium. So the endocarditis is the inflammation of your endocardium. And one of the cause of endocarditis is, of course, bacterial infection. Now back to the tricuspid valve a little bit. So why does the IV drug user more prone to having tricuspid valvular disease than any other valve in the heart? Well, imagine this. Usually IV drug user, they reuse the needle, right? And that's going to be some bacteria on the needle. Usually Staphylococcus aureus or something like that will be on the needle. And when the patient injects themselves with the blood, that bacteria will go into that bloodstream too. And that bacteria in the bloodstream will make its way eventually back to the heart, right? And which valve would the bacteria pass first? The bacteria would pass through the tricuspid valve first, right? The valve between the left atrium and the left ventricle. So that's the first valve. So the bacteria will pass through that valve first, and they will be able to deposit and colonize onto the endocardium and onto the tricuspid valve itself, causing inflammation and infection and endocarditis. And you may wonder why the bacteria from the IV drug user, why is it less likely to cause any valvular disease on the left side of the heart, say the mitral valve? Why is that? Well, you have to imagine that the left side of the heart is more high pressure, right? The blood flow through the left side of the heart with high pressure, there's more turbulent blood flow. And more turbulent blood flow in high pressure environment, that makes it very hard for the bacteria to deposit onto the endocardium. Makes it hard for the bacteria to colonize onto the valve on the left side. But on the right side, the bacteria will reach the tricuspid valve first, and the bacteria will have time to deposit onto the endocardium and cause infection, cause inflammation, and cause endocarditis, which the bacteria on the valve of the tricuspid valve, it can cause damage to the structure called a tendon near to the cords. So that will cause a problem of tricuspid regurgitation when there is ventricular systole, and the blood will regurgitate back from the right ventricle onto the right into the right atrium. So with tricuspid regurgitation, what kind of symptoms can we expect to see? And tricuspid regurgitation is pretty much similar to right-sided heart failure, right? Because with the regurgitation, the right ventricle isn't able to push the same amount of blood into the lungs because there's a regurgitation. The blood's going to move back from the right ventricle into your right atrium during ventricular systole. So when the blood backs up, it can back up into your superior vena cava, into your inferior vena cava, and that's going to cause peripheral edema, right? And you can also see JVD in the patient, jugular venous distension, distended neck vein, because the blood is backing up. You may see ascites also, and these are some of the physical signs that you're going to see. And also endocarditis, that's an infection, right? So what are you going to see? You're going to see the patient being tired, weakness, you can see fatigue, you can see fever, you can see night sweat. Also, you might see patient having shortness of breath. And also, a telltale sign of tricuspid regurgitation is when you auscultate the patient. You might hear a murmur called a pan-systolic murmur. So that's a telltale sign of that the patient has tricuspid regurgitation is pan-systolic murmur. So in a board exam such as the USMLE, every word in the question stem is meaningful. So if you see in the question stem a clue that the patient is an IV drug user and he has symptom of peripheral edema and a sign of infection, fever, night sweat, and things like that, you have to think that one of the differential is that the patient is suffering from tricuspid regurgitation. So in an exam like USMLE, word association is very important. Word association is very big in these sort of exams. Some words in the question stem would trigger you to think of certain differential. And of course, you have to use your common sense too and look at the details. Age, sex, race, things like this are very important to give you clues of what you should be thinking about when you're looking at these questions. I'll give you an example. A 19-year-old woman comes to your office with breast mass. So you can't be concluding that this girl has cancer or even tumor or anything like that. You have to look at the question, right? Look at the details. She's only 19 years old. So 19-year-old with breast mass, you should be thinking more in the line of maybe fibrocystic breast changes, with maybe she's about to have a period, and then when you have a period, your hormones goes up and down, and that will cause breast tenderness. So this is just an example of like you have to look at all the detail, age of the patient, the sex, and the social habits and everything like that. You can't just jump to detail with these questions. Everything they give you on the USMLE in the question, that's a clue. Okay, the next valve on the right side of the heart is the pulmonary valve, and usually in the board exams, they like to ask congenital problem associating with the pulmonary valve, and most of the questions is embryology questions. So you might see some question about tetralogy of Fallot. With tetralogy of Fallot, usually the patient or the kid will have mitral valve stenosis. So you're gonna see that. And the next clinical relevance of the valve, I want to concentrate on the aortic valve, and I'm going to save the mitral valve to last because usually so many questions are on the mitral valve, so I'm going to save that to last. So the aortic valve, so you might see aortic regurgitation or aortic valve insufficiency. And what is that? That is when your aortic valve doesn't close tight enough and there's a leakage. So your left ventricle will pump the oxygenated blood from your left ventricle to your aorta and to the rest of your body. But that's but the valve, the aortic valve, doesn't close tight enough, and that blood will leak back. That blood will leak back from the aorta into your left ventricle, especially during ventricular diastole, when the heart dilates, and the blood from the aorta shouldn't be coming back to your left ventricle. It should be going out to your systemic circulation. But if there's if the valve is insufficient, if the valve doesn't close tight enough, there could be a leakage, and the blood that's supposed to go out to the rest of your body can leak back into your left ventricle. And what kind of symptoms can you see with that? You can see the patient being tired, fatigue, and you can see cyanosis also. So why do these symptoms occur? Why do you see these symptoms? Because simply, if the blood is leaking back, if the oxygenated blood that's supposed to be going out to the rest of your body is leaking back into your left ventricle, you're losing cardiac output, right? And that blood that oxygenated blood that's supposed to be going to the rest of your body with oxygen and everything, it's not, it's not going out there enough. And some part of your body, such as your brain, your tissue, your organ, is not getting enough oxygen in that oxygenated blood, because that blood is leaking back into your left atrium. So it's not going to your brain, it's not going, going to your tissue. So you're losing cardiac output, you're losing oxygenated blood. So that's why there's some symptoms of tired, fatigue, and even cyanosis, because you're losing cardiac output with aortic regurgitation. The patient may be shortness of breath, and a good physical sign of aortic regurgitation is head bobbing. Head bobbing with bounding forceful pulse. And this is a good telltale sign on the test. When you see these words on the test, you should be thinking about aortic regurgitation. Is patient having physical sign of head bobbing, and forceful bounding pulse. Why does that happen? Why does the head bobbing happen? Well, imagine this: the left ventricle is pumping the oxygenated blood up the aorta, through the carotid, and through the rest of the body, right? And when the blood reaches your carotid, and the blood leaks back into your heart, so the blood goes up the carotid and then comes down. So the blood goes up to the carotid and then a little bit comes down back to your left ventricle. So when the blood goes up and down the carotid, your head bobs. Your head bobs like that. So that's a physical sign of head bobbing, because the blood goes up to your carotid and then comes back down, because the blood leaks back into your left ventricle, because the aortic valve doesn't close tight enough during ventricular diastole, and that causes wide pulse pressure. And also with aortic regurgitation, you might see that the patient have left ventricular hypertrophy, so the muscle of your left ventricle becomes bigger. Why do you think that? It's a compensation, right? Because you're losing cardiac output. You're not pumping out enough blood to the rest of your body, because your blood keeps on leaking back into your left ventricle. So your left ventricle try to compensate by bringing the blood out by pumping harder. And when the left ventricle pumps harder for a long period of time, the muscle becomes bigger, and that's the reason that we see left ventricular hypertrophy, because it tried to compensate for the blood leaking back into the left ventricle. It's trying to compensate for lower than normal cardiac output. And what's the cause of aortic regurgitation? So aging is one of them, hypertension, something that we call aortic dissection, and that's basically there's a tear in your aorta. When there's a tear in your aorta, the blood can leak back into your left ventricle, and that can cause from hypertension. That can be aortic dissection, can be from hypertension, or it can be from trauma. Anything that causes the root of the aorta to dilate can lead to aortic regurgitation, because the valve will not be tight, right? If there's a dilation of the root of aorta, and a condition, connective tissue condition like marfan can be one, the marfan syndrome, and of course lupus can cause aortic regurgitation, and also of course endocarditis can cause aortic regurgitation. So these things you should think about, or should trigger you to think of aortic regurgitation on the test when you see some of these things that we just talked about. So now let's go over to the mitral valve. And as I've said, on your board exam, the most commonly tested valve defect will evolve around your mitral valve, because that's a very high pressure area, right? And let's start with mitral valve prolapse. And this is a very common valvular disease that you're going to see in young women, and usually it's asymptomatic, and you're going to see this during ventricular systole. So ventricular systole is when the heart pumps, and you can see the leaflet of the mitral valve bulges. So it bulges or it prolapses into the left atrium, so like a parachute. But the patient will be asymptomatic. The patient would usually not have any symptoms, and usually they'll be diagnosed by incidental findings. So the patient, a young woman, will go to the doctor. The doctor will do yearly physical, like auscultate the heart, and the doctor might say, "Oh, I hear a murmur," and the murmur will be a mid-systolic click, followed by a late murmur. So he's gonna hear that. The doctor is gonna hear that, and when the doctor hears the click, when the doctor auscultates the patient, the click, that's the prolapse. The click is the prolapse, and the murmur is usually the blood regurgitating from the left ventricle into the left atrium. So if that's a short murmur, that means like not a lot of blood is regurgitating back from the left ventricle into the left atrium. But if there's a long murmur, that means a lot of blood is regurgitating back from the left ventricle into the left atrium. So as I said, usually with mitral valve prolapse, there isn't much symptoms, or there aren't any symptoms at all. So why does this happen? Well, usually the tissue of the leaflets of the valve, of the mitral valve, kind of stretch too much, and that makes the valve becomes kind of floppy, and that causes causing during ventricular systole for the valve to prolapse into the left atrium like a parachute, and this is quite common in disorder that involve connective tissue, like Marfan syndrome, where there's a connective tissue problem causing some of the tissue to stretch a little bit. And then, of course, I mentioned, usually the patient is asymptomatic, and the finding is usually incidental finding. But if the doctor diagnosed the patient with mitral valve prolapse, the doctor might want to give the patient some kind of beta blocker, so the patient can take beta blocker to slow down the contractility of the heart, and that kind of prevent any complications such as mitral valve regurgitation. So prevent regurgitation, and also beta blocker would prevent arrhythmia, which is a complication of mitral valve prolapse. But usually with mitral valve prolapse, it's very benign. Patient would not have any symptoms at all. So if the patient with mitral valve prolapse have any symptoms, it's because of a complication, because with the prolapse, the blood is also regurgitating back from the left ventricle into the left atrium, and that will cause some kind of symptoms. So what kind of symptoms might we see from a patient with mitral valve prolapse, and also with mitral valve regurgitation with the prolapse? So imagine now the blood is regurgitating from the left ventricle into the left atrium during ventricular systole, right? So you're losing cardiac output. The blood with oxygen is not pumping out to your systemic circulation with the same amount, right? So less oxygenated blood out. So what would that cause? Tired, weakness, dizziness, things like that, right? Because your organs such as your brain, your tissue, your things like that, they're not getting enough oxygen, or the usual amount of oxygen as they're supposed to, because that's a regurgitation. So you're going to feel weakness, fatigue, dizziness, things like that, just because the cardiac output is lower than usual a little bit, because that's a regurgitation. Also, the patient might have a symptom of shortness of breath. Why is that? If the blood regurgitates back from the left ventricle into the left atrium, it can push that blood can push back into the lungs, right? And when the blood goes to the lung, there's a risk of pulmonary edema, and that's going to cause the patient to have problem with breathing and stuff like that too, and also complication of mitral prolapse is arrhythmia, and also another complication is infective endocarditis. So these are the things that you should be thinking about when we talk about mitral valve prolapse and its complication. Now, just to continue on with mitral valve regurgitation or mitral valve insufficiency, right? As I said just now, this could be a complication of mitral valve prolapse. But what can cause mitral valve insufficiency? What else can cause mitral valve regurgitation? So, infective endocarditis, right? So that's going to cause a damage to your chordae tendineae, which will prevent the valve from closing properly during ventricular systole. What else? Myocardial infarction, MI, right? So myocardial infarction is when your heart muscle, your cardiac muscle, isn't getting enough blood supply and the cell starts to die off and it loses its function. So this can happen to a very important muscle, the papillary muscle, right? So the papillary muscle can be affected during myocardial infarction. And so what happens is if that papillary muscle dies, the cell dies, it's not going to contract. It's not going to pull the chordae tendineae. It's not going to pull the cord. It's not going to pull the valve closed tightly as it before. So myocardial infarction can affect papillary muscle, which can affect the closing of the valve by not pulling on the chordae tendineae. And also, what else can cause mitral valve regurgitation? Anything that causes left ventricular dilatation, anything that causes left ventricle to dilate. So, chronic alcohol abuse, infection, anything like that that causes the left ventricle to dilate. Why is that? So if the left ventricle dilate, right, that affects the fibrous ring, that affects the mitral annulus ring. So it doesn't seal off or it doesn't close tightly when the valve closes enough, because there's a dilation, and the dilation will force the ring, the mitral annulus to change its shape. It doesn't seal off correctly. So when that pumps, when your left ventricle pumps, the blood will leak back into your left atrium. So the last thing we're going to talk about today is mitral valve stenosis. And mitral valve stenosis is the thickening or the narrowing of the mitral valve, right? So there's going to be some trouble filling the left ventricle during ventricular diastole, because the valve is narrowed. Mitral valve is narrowed. So what can we see? So with the mitral valve stenosis, the blood may be backing up into your lungs. So you might see pulmonary edema. So you're going to see patient maybe having shortness of breath and things like that. You're going to see patient feeling fatigue, weakness, tiredness, and that's simply because, again, the blood is not flowing to the left ventricle with the right amount, and that amount is less than usual. That's the left ventricle is pumping out to the rest of the body, and the rest of the body is not receiving the usual amount of oxygenated blood. So that's going to cause weakness, because your brain, your tissue, your organs not getting enough oxygen as it should. So that's the reason the patient should feel fatigued and tired and things like that. And also the cause, normal aging, the mitral valve will narrow because of calcification build up when you age. And also another thing is that it's common for mitral valve stenosis that you might see on the test is rheumatic fever. Rheumatic fever will cause your mitral valve to thicken. But in the United States, normally we don't see rheumatic fever much anymore. So if they want to test rheumatic fever and mitral valve stenosis, you should look in the question stem. The question stem should mention that the patient is a foreign patient, or maybe they'll say something like the patient is an exchange student from overseas or something like that, and then you can think about rheumatic fever as one of the answer choice. Also, they might test something about stroke and cerebral embolism with mitral valve stenosis. So basically, with the mitral valve stenosis, with the thickening of the mitral valve, a blood clot may break off and travel through the left ventricle and onto the aorta and into the carotid and into your brain, and cause some kind of stroke. So that is something that you should be on the lookout for as well. So I think that's it for today. We talked a lot about clinical relevance and what you can expect on your test, what kind of question they like to test you on. And I really hope you find this useful and helpful. I guess I'll see you next time with more anatomy tutor. I'm Dr. Chuck with CMEC.